At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Good afternoon, good morning to those out west. This is Dennis Jokas, CTO with Canada Health Infoway. I'd like to welcome you to our latest webinar covering our most recently published white paper on clinical analytics in primary care, and this is around the use and reuse of data within the EMR for informed decision making. Just a few housekeeping notes before we get started. Just to let everyone know, we are recording this particular webinar, and the recording will be posted on our website. In addition to that, we will post both English and French versions of the presentation on our website as well, and that should be available in about a week's time. Just as a reminder, we would entertain your questions. We'll leave about 20 minutes toward the end of the webinar to address the various questions we get. Please use the Q&A function on the webinar panel to input your questions, and we'll take those, as I said, at the end of the webinar. Once again, a disclaimer, this webinar represents the views of Infoway. It's meant to be informative only. We might mention some technologies or some groups that we've analyzed in the context of the analysis for this particular paper. It's not meant to be an endorsement of any of those parties. So what I'd like to do now is turn it over to Mark Nenadovic. Mark is a group director in the Emerging Technology Group, and he led the initiative to research and develop this particular white paper on clinical analytics in primary care. Mark, I'll turn it over to you.
Thanks very much, Dennis, and let me extend my welcome to everyone who are joining us today. We appreciate the time you're taking out of your day to hear about this story, a story that we are quite excited to share with you. We feel it's a story of inspiration. It's about groups of primary care clinicians who have been leading the way for their profession in delivering value to their communities through the enhanced use of electronic medical records. Now, these clinicians have used their electronic data as an enabler, and that is an enabler to bring value to their practices. By analyzing their data, they've learned a great deal about their patients, and they've learned a lot about themselves. They've used the newfound insights to lead improvements in care processes and to achieve improved patient outcomes. Now, what they do actually shouldn't be that difficult to undertake, yet many have had to overcome obstacles to get to where they are today. So today's webinar is about their story. It provides an overview of our most recent clinical white paper, as Dennis has introduced. It shed light on the experience of many of the early adopters in this space. And in researching and writing our white paper, we interviewed several primary care clinicians from across Canada and others internationally to understand the current state of the use of analytics. In our paper and in today's webinar, we'll discuss the value proposition, some of the barriers that have been experienced and overcome by these early adopters. We'll include discussion around considerations for moving forward, and the presentation will end with a call to action. And that's very simply a path that we think that other primary clinicians can follow, including other stakeholders such as vendors. I wanted to start with a quote that caught my eye. Dr. Sanjeev Goel has distinguished himself in providing leadership in the application of clinical analytics. He was part of a panel that was featured in the Medical Post in the fall of last year, and this quote caught my eye, and it's a very simple quote. Sanjeev is saying, data collection might be the most important advantage that these new technologies have offered healthcare. And what he really meant was not so much the capture of the data, but the use of the data. And his continuing comment here was that if you were to ask a family physician how many people that they had helped quit smoking, they wouldn't be able to tell you in the past. And he's referring to a paper-based chart environment. And that helping a patient quit smoking is probably the most effective thing that a patient could do. So his comment raised other questions for us as we tried to understand how family practice clinicians were using their EMRs to answer basic questions about their patients and basic questions about their practice's performance. we knew that more than 3/4 of Canada's family health physicians had adopted EMRs. And so it was an obvious opportunity for us to look a little deeper at the use of those EMRs. We went to a very recent source for clues, including, in this case, the Commonwealth Fund Survey of Primary Care Physicians from 10 nations, which was published in December of 2010. The middle column here in blue is the average of those 10 nations, and the column on the right, of course, is Canada's performance. And it was very simple kind of questions that we were looking for, such as, can you list patients who are due or overdue for tests for preventative care? And you can see that on average, among those 10 nations, about 70% of physicians can do that, but in Canada, the rate is somewhat lower at 48%. Other simple kind of queries or functions that an EMR could offer to their practitioners, including generating reminders and notices when it's time for regular and preventative care and follow-up, and generating reminders for guideline-based interventions. And you can see, once again, that the rates on average are much higher than what Canada has experienced. We have one more slide to give us a little insight into the current context of the use of EMRs to support performance measurement and quality improvement. And we can see again that Canada's rate has lagged that of its peers in those 10 countries. So, for example, our Canadian physicians reviewing their clinical performance against targets at least annually. You can see about 4 in 10 physicians are doing that in Canada versus 5 in 10 among the 10 countries. But also, we can see that Canadian physicians are trailing the performance of their peers in the other countries in areas such as receiving information on how clinical performance of their practice compares to that of other practices. So benchmarking, peer comparisons. And we can see that about 1 in 5 Canadian physicians, 1 in 4 Canadian physicians measure patient outcomes or experiences. So while Canada's adoption rate of EMRs has climbed quickly over the past decade, the enhanced use of EMRs trails the international average for basic analytical functions that can support performance measurement and quality improvement analysis. So for a lot of Canadian physicians, the EMR represents a lot of data, but limited information. In fact, in some of the interviews that we did, physicians told me that their EMRs are, to them, represent simply electronic filing cabinets, the e-version of a paper-based chart practice. And this represents a significant challenge for the profession. How do we harness the power and potential of the ever-increasing store of electronic patient data in the primary care sector? Most EMRs contain non-standard, unstructured, and free text notes, such as scanned documents. Those data are not easily computable. Of course, the ideal is that the EMR must be more than a simple digital paper record. It must function as a decision support tool and include algorithms and analytics that can individualize and improve the care of patients. So what value can be created through the analysis of the EMR? Well, we thought of it on 3 levels: the patient, the practice, and the population level. And a key theme that emerged for us in research in the white paper is that the use of analytics in primary care needs to be coupled with evidence so that it adds value to patients and those involved in their care and treatment. There's little doubt of the potential that can be realized from analyzing and sharing clinical data with individual practices and in aggregate at the regional and jurisdictional levels. For example, at the patient level, data-driven alerts and reminders can assist clinicians to provide individual patients with the right care at the right time. Analytics can assist with prevention, screening, and chronic disease management. At a practice level, analytics generated as part of a benchmarking initiative can inform individual clinicians and teams about how they performed against specific clinical targets or quality metrics and how their practice performance compares to their peers. Perhaps it may be in relation to their compliance against the standard of care for patients with chronic conditions such as diabetes. At a population level, EMR data can be used to support broader community, regional, or jurisdictional purposes. Ministries of health or health system researchers can conduct work to view the performance of a system from various angles and objectives, including items such as drug safety surveillance. They can assess the impact of policy levers and program investments on the performance of the healthcare system using aggregated electronic medical record data. So let's move forward and look at a specific example of analytics. The simplest type of analytics is really a simple numerator and denominator. It's a descriptive analytic. It really focuses on what has happened in the past. An example of a descriptive analytics might be a query that produces a summarized list of patients with diabetes that haven't been seen by their primary health care team in more than a year for the management of their condition. So it starts with a basic question or improvement objective. A great example that we found through our research for the white paper was Dr. Griever's team at the North York Family Health Organization. That family health team has been a leader in the area of the use of analytics. And in fact, analytic-driven reminders for cancer screening contributed to high performance for their particular organization. As we can see, there's 3 measures here for screening for mammography, using fecal occult blood tests and pap smears. They're the bar on the left, the orange-colored bar, and you can see that they've outperformed the local LIN that they're part of and, of course, the entire province of Ontario. Dr. Griever told me that the focus of analytics as part of the treatment of these patients resulted in 10,300 more cancer screenings, and they estimated that it saved 206 lives through early detection and treatment of disease. A second example of analytics is a more advanced type, and that's predictive analytics. And it's focused on what may happen in the future. This analysis uses structured and unstructured data, could be data from various data sources, including the EMR. And it can predict, for example, which patients may be at risk of a serious health setback, leading to costly interactions with the healthcare system. I think what we found out, which probably you can all agree to, is that very few organizations, even larger endowed organizations such as hospitals, are using predictive analytics. It tends to be early adopters in that space as well, and there's much less prevalence of the use of predictive analytics in primary care settings, although there are some exceptions. What a lot of people may not realize is that a simple and a long-standing risk predictor is a form of predictive analytics. The Framingham risk score, an example of a tool, and this tool can be found in several EMRs, including EMRs, Canadian EMRs, is an example of a tool that employs an algorithm that uses a small number of data points to provide a prediction. In this case, a patient's risk of developing cardiovascular disease within the next 10 years. In our example, I've used 8 data points and entered it into the risk score, and it's hypothetical, by the way. And in this case, these data points include a patient's age, their gender, cholesterol values, blood pressure. You can read those fields, hopefully, from where you are. And by hitting that calculate risk button, it takes just a few seconds for it to pump out the risk score. In this case, this hypothetical patient is at a high risk for developing cardiovascular disease over the next 10 years. Now, the output also assists clinicians in determining whether the patient is likely to benefit from lifestyle changes and preventative medication to lower blood pressure and cholesterol levels. You'll note in that second lower window in the middle column, there are some advice in relation that have been derived, rather, from the Canadian cholesterol guidelines. So just for fun, I'm not a clinician, so I may be exaggerating the benefit of this lifestyle change. I kept 7 of our data points the same, and I made our hypothetical patient now a non-smoker or someone who might stop smoking. Clicked on that risk calculator, and this predictive analytic model was able to provide the new calculated Framingham risk score, which is now at almost half, 15%, moving that patient to a moderated risk level. So the example really illustrates how predictive analytics can be an effective tool to personalize treatment for a patient, but also to act as a patient education tool. And primary care physicians using predictive analytics are clearly quarterbacking a lot of the chronic disease management of their patient and are in an excellent position to use these type of tools to affect changes in their patient's health status. We want to bring to you some of the other examples that we found in researching our white paper, and we were very, very pleased that as we conducted an environmental scan across Canada, we found many examples of use analytics in primary care. We found local initiatives, we found provincial initiatives, we found regional and national initiatives. Many of these programs I'm about to present to you were led and governed by clinician researchers. These are folks who take a bottom-up approach to using their EMR data to improve the health of their communities while giving due attention to privacy. One of the first established and largest primary research networks in Canada is the Canadian Primary Care Sentinel Surveillance Research, which many of you will be familiar with, better known as Simpson. It was founded in 2008 and involves more than 400 physician practices, about 750 physicians, and approximately 1 million patients in 7 different jurisdictions within Canada. I have examples of several other initiatives here, and pleased to say that we found them coast to coast, and I'm probably underrepresenting them here. In fact, in the paper we say these are simply a sample of, that we generated through an environmental scan, but there were others that didn't make it into the paper or part of this presentation. But we did have a couple of takeaways as we completed that environmental scan. The first is that this is very much an emerging area. We are literally at the thin edge of the wedge in terms of practice engagement. You know, I just finished telling you the metrics around Simpson in terms of their physician engagement. Many others involve hundreds or even tens of physicians and practices. And you contrast that to a market of approximately 30,000 family physicians, you know that we've got a long way to go. The second observation for us is that many of these initiatives have been anchored by research grants and not operational funding. Or in some cases, some of them have been anchored by both research and some operational dollars. But there is a reliance on temporary funding, and that has resulted in some of this activity ending and having to wrap up, and others have experienced constrained growth and, not surprisingly, challenges with operational sustainability. So there's little doubt in our mind that there's been some terrific pioneering work by handfuls of clinician leaders across the country. Our hope is that for the momentum to continue to build within the sector and for growth and sustainability challenges to be resolved. I'm going to take us to one of these initiatives, and it's ICE's Emerald database, and specifically their Sapphire tool, which is a system for audit and feedback to improve care. Sapphire is important to spend a couple of moments on, and it's from a visualization perspective. I've already talking about the importance of both data and analytics. I guess the third leg of that stool that really adds value to that value chain of analytics is visualization. And so here we have a representation of a dashboard that is provided to participating physicians. I think there's about 400 that are participating in Emerald's Sapphire initiative here. And we can see that this dashboard includes tables and charts. We can see that it includes effective use of color to draw a provider's attention to areas that may require attention. In this case, we're comparing an individual physician's practice as it relates to diabetic care management to the top 10% performers within that database of physicians. And so that physician is able to see that there is room for improvement, that best practices far exceeds their current performance. The nice thing about this tool is that it enables physicians to drill down to individual patient levels. So you probably can't read that well. I know it's a lot of information, but essentially we have rows of patients that are identified by numbers in the left column, and then each of those 9 indicators kind of continue across to the right, and in fact, you don't see all of them on this image. it does enable physicians to identify where some practice change needs to happen, where perhaps a patient needs to be called in for appropriate care and intervention. But I want to highlight one other issue that I noticed when I was including this in my deck just a day or so ago. And if I click on it, we'll see that I've put in here a bunch of circles. We've got 8 in total. And unless I've incorrectly interpreted this, and if I have, my apologies to Dr. Karen Tu and her terrific team at ISIS. But what I want to do is underscore a common issue that is observed in data analytics at its current state. And so first let me explain these dots. You'll see that the top 4, representing 2 patients here, that in the far left column, they have been diagnosed in the cumulative patient profile as having diabetes. Yet if we look at the next column over to the right, which reads, if you can't read it, it's about diagnosis from lab results presumably and from drugs that are obviously prescribed within their patient record, that it doesn't seem that diagnosis does not seem to be supported by the diagnostic results nor the prescription of medication for diabetes. And the bottom 2 are just the reverse. We see what appears to be in that right column a confirmation of diabetes on the basis of diagnostic testing and perhaps prescribed medications, yet the CPP does not include a diagnosis of diabetes. So what is the point I'm trying to make? I know that we talked about visualization here, but I'm kind of bringing us back to data. And the point I'm trying to make is the impact of poor quality coding, especially if it continues to persist within a practice. Clinicians will become conditioned to not trust EMR notifications, reminders, search results, and quality reports if data quality is a persistent problem. So this is a nice segue into our next slide, which brings out a couple of points, one in relation to data quality, and the other in relation to an application analytics that goes beyond caring for patients and improving their outcomes. Project ALIVE, which stands for Advancing and Leveraging the Investment of EMRs, was undertaken at the Waterloo Wellington LHIN with participation from area family health teams, including the New Vision Family Health Team in Kitchener, Ontario. One part of the project looked at billing codes and concluded that there had been missing billings, resulting in lost revenues. As a result of the analysis, the project developed strategies on how to prevent missed billings from happening in the future. Again, another example of the quality of coding that has a downstream impact. So I did, at the top of this talk, mention that we looked internationally at some of the other practices. Our research included scans of practice in other countries, including the U.S. Many of you are familiar that the Accountable Care Organization program was started in 2011, and it introduced a change in payment models from a fee-for-service to a pay-for-performance to drive clinical behavior with a focus on cost, quality, and satisfaction. And it got us to thinking about the empowerment of social media and web-based crowdsourcing for information. You'll know that there are several doctor rating sites that have proliferated on the internet over the last few years, allowing patients to anonymously post review comments about their experiences with their physicians. If you've happened to visit these sites, maybe you've even contributed to them, you know that the crowdsourced wisdom is often biased towards positive reviews, mixed in with the odd hater. RateMyMD.com, reputed to be the largest of its kind, captures patient satisfaction ratings on 4 dimensions that include office staff and the physician's punctuality, his or her helpfulness, and his or her knowledge about your particular complaint. No doubt that this information would help someone choose a physician. It might steer them toward one, it might steer them away from one. But should we trust anonymous opinions and anonymous judgments of a physician's quote-unquote knowledge? Now imagine if a patient could select a practice or even an individual physician on the basis of their past performance on a set of quality metrics that relates to provincial or national standards of care. We found a similar kind of model in the States through these ACOs. This is a screen scrape of practice in Massachusetts. ATRS is one of 32 pioneer ACOs, and they're paid on the basis of the quality of the care delivered to their patients. So analytics has played an important role in their ability to continue to measure and review their performance using state and national benchmarks to improve the way they deliver care to their patients. Of note is the transparency by which this organization disseminates its performance results. As you can see, this is their website. There is this menu that includes quality measures, and if you were to click on that menu item, 30 different quality measures are disseminated to the public. This next page shows their performance on colorectal cancer screening. And we can see here that this organization, through their use of their analytics, has continuously improved their screening rates from mid-80s to upper 80s for colorectal cancer screening for eligible patients. But more importantly, you can see that they've greatly outperformed the national average, which is closer to 63%, the top 10%, which is at 74%, and then their local Massachusetts Health Quality Partners average, which is near to 78%. We found another organization, some of you may be familiar with the Southeastern Texas Medical Association in Texas, of course, and they're a mid-sized physician group with approximately 40 providers and 250 employees. In 2011, they were named one of 30 exemplary practices for clinical decision support in the United States by the Office of the National Coordinator of Health Information Technology. Transparency of quality measures at SETMA is used to achieve superior patient-centered care. In 2009, SETMA began to publicly report quality metric performance by provider name. And this is a bit hard to read, but I'll interpret it for you. You can see that individual physicians are named in the second from the left column. And in this case, a set of metrics for the care of older adults is in the 4 columns to the right of the provider's name. We can see here that Dr. Shepard, who is a real physician in 2011, was performing poorly and was garnering red highlights on his performance, and with ratings of 0% activity in the area of counseling for physical activities. 16% of his patients were screened for colorectal cancer, and 28% of them had a fall risk assessment, falling below the expectation of performance for physicians within SETMA. The top narrative above this says a couple of things. It says, well, listen, don't worry about that clinic with all of the red, which Dr. Shepard belongs to. It's new, all the providers are new, and they will improve the performance. There is a process for them to do so. They use these reports, they have quality councils, they sit down, and they design ways in which to improve performance. And I thought, I wonder if that's just marketing or whether that's true. And so I fast-forwarded to 2014, and we can see that Dr. Shepard has indeed improved his performance on the 3 measures for the care of older adults, and the values are provided there, 78% to 0%, and the red highlights are gone. SETMA believes that disclosing physician-level performance illuminates areas of excellence and areas needing improvement. They believe it drives provider practice standards higher, and it serves to bolster patient confidence in SETMA's services. So to summarize the last few slides of this section, a couple of observations. We note that the descriptive analytics is the most common form that's used in primary care. Its application has been largely in the areas of preventative screening and the care of populations with chronic conditions. We've also noted the importance of high-quality standardized data to support downstream analysis, reporting, and quality improvement. Additionally, visualization tools such as the use of dashboards can help clinicians identify and validate the need for care interventions among their patients. So while some of the initiatives that we reviewed had expanded beyond basic descriptive analytics, the next step for many is for many of these early adopters is to introduce predictive and prescriptive modeling and to link their data sets, to other data sets in order to optimize and personalize treatments for their patients. We also believe that these early adopters should focus on increasing the availability of such analytic results to near or real time and ideally deliver those results in the context of the patient's visit. For those who have yet to do so, we recommend that they also consider newer technologies such as natural language processing that can read text blobs, extract data elements, analyze them, and map them into structured and reliably computable information such as SNOMED CT terms. And of course, from there, we can support analysis quite readily. So we talked to a lot of these folks. We talked to them about some of their experience, and we've put together a set of slides that really we've titled Action Considerations that have been informed by these early adopters. And probably the first thing, as I've hinted at the top of this presentation, is the barriers. For many of them to get to where they are today, they've had to solve for a number of issues. And we acknowledge that physicians in the primary care setting face greater challenges in their advanced use of EMR functions and features with fewer resources available to support their improvement activities, and obviously far less supportive than practicing physicians in inpatient settings. There are many real and perceived reasons to help explain why primary care clinicians have not embraced analytics and more advanced use of their EMRs. Many can attribute the current state to the technological capabilities of their EMRs. However, non-technical issues also exist to impede adoption. I guess one of the first issues that have come up, I had some really nice graffiti font here, but I see they didn't replicate onto this slide version. I'm sorry about that. So this might get a little messy. I'll try to walk you through it in speaking notes. One of the things that we discovered, and remember, we were talking to the choir, the folks that were converted to the use of analytics. They were convinced that the value proposition wasn't commonly understood by their peers, that folks didn't necessarily understand why analytics would add value to their practice, and importantly, linked to value proposition was this issue of control. For many physicians, there is a fear, a distrust, if you will, about how practice data may be used by others, such as government or regulatory organizations, et cetera. And there is concern in releasing data from their practice. Now, of course, this has been solved by many through governance mechanisms, through data use agreements, and through mandates to support research and quality improvements. Another set of barriers that folks have experienced is as it relates to data standards. As we've already mentioned, in its current state, most EMR data is non-standard. It's unstructured. It consists of large amounts of free text. Some have estimated that as much as 80% of EMR data is unstructured, and as such, it's not easily computable. Moreover, working with that data requires a lot of cleansing and processing of that data before analysis and reporting can take place. Again, a lot of our early adopters have solved for ways to extract data and to standardize that data so that it can support downstream uses. Data extraction is another issue that we heard about. Some primary care physicians can't access their data. Those systems are locked down, and it's really a call on vendors to open up their systems to allow data to be extracted in a simple and standardized way. But beyond that, even to open up data dictionaries and any mapping kind of information that would support researchers and quality improvement networks. There was also concerns around the EMR functionality, and we've talked about many of them already, but basic data entry tasks can be time-consuming, querying and reviewing can be difficult, which results in productivity losses and in some cases potential risks to patient safety. Others reported issues that included slow and inaccurate patient retrieval, patient information retrieval, and the lack of query functionality, especially for unstructured data, and of course challenges around visualizing data. Privacy was another challenge that many of our early adopters had to overcome, And it really began with, ensuring that their confidential handling of personal information was in line with applicable privacy and legislative regulations. As we've noted already, sharing of data should be supported by a data sharing agreement that clearly states the terms and conditions for the use of those data. Several of the early adopters have protected personal health information through de-identification and encryption techniques or through record aggregation, basically extracting data from the EMR without direct or indirect personal identifiers. Now, that's not everyone's case, but some have taken that approach. That is supposed to say governance. And governance issues have included a lack of clarity surrounding leadership, roles, and responsibility, what data is to be collected by whom, who the data can be shared with, and for what purposes. These are important interests, and they must be solved to adequately stand up an effective initiative such as a research or quality improvement initiative. Once again, a role for governance in managing the use of data. I have a couple more for you. Skills is our next one that we want to talk to, and this is an obvious one. You've probably been thinking about it since the start of this presentation. There is a real need for skill and capacity building through education and peer support. Within the practice, they're going to need support to provide learning and development opportunities to engage in processes that are related to data governance, to engage in privacy, safeguard and privacy enhanced management of personal health information, appropriate use of technologies, scope management, and informatics. At its simplest state, clinicians will need to be trained to ask the right questions of their data, to be able to interpret that data, and to be able to act on it to deliver the value that is promised. But importantly, many practices in the primary care sector need skilled resources, particularly in the case of the use of advanced analytics. There will be a need for professionals such as data scientists who can design algorithms, use advanced technologies in order to deliver those valuable insights. And our last point that many of our early adopters have been able to resolve, at least on a temporary basis, my former comments as it relates to research-anchored initiatives, is money. It's a precious resource. We've mentioned already the need for resource and funding for capital expenditures and to maintain operations. But for individual providers, they need to be able to assess the total cost of ownership of any analytical solutions that they may bring into their practice, or they may participate as part of a shared initiative. There needs to be clear value propositions to support investment decisions. So let's assume that you're not yet engaged in the use of analytics in your primary care practice. A first step is likely to plan and create a future state set of objectives and to match them with a deployment model that can best meet those needs. For example, if a practice wishes to perform basic search, query, retrieval, and reporting with a focus on descriptive analytics, they might be best able to do that using their local electronic medical record. It should have the capability to meet those needs. This approach is probably most realistic and feasible when all of the data is resident in the EMR system and their analytics are not compute intensive. Our next couple of slides will really draw our attention to the capabilities that one should look for from their electronic medical record to support analytics. So from a data quality extraction perspective, we're going to want our solution to use common data standards. We're going to want some assistance with implementing those data from our patient assessment, the use of pick lists to reduce free text. And of course, we do want the ability to extract a minimum data set from our EMRs. From a process perspective, we want a tool that's going to assist us with standardized assessments and treatment of common clinical conditions. We want the benefit of notification and alerts so that we can deliver the right care at the right time or immunization through the lifespan of a patient. And of course, as we've mentioned already, local EMRs, that's the EMR that's deployed in your office, should be able to provide a minimum capability in relation to analytics and data visualization, including basic search and query and reporting, and the ability to track key clinical conditions for reporting of chronic diseases. We believe that risk calculators should be part of a standard EMR, and that there should be some form of visualization, possibly a dashboard or other format. Now, if we were to engage in more advanced use of analytics, we're likely going to have to step outside the practice, likely going to have to pool our resources with shared initiatives or trusted third parties that can deliver both capital equipment and infrastructure as listed on this slide in the first section, but also advanced capabilities such as dynamic querying, business intelligence, slicing and dicing of data, important services such as benchmarking to peers in relation to a standard set of indicators. And where we're getting into a lot of data linkage, we would want our provider to have tools that would enable them to identify and link patient data from multiple different sources. Many of these types of advanced services could be delivered from providers as a software as a service or through a cloud offering. So with the majority of Canadian primary care practices now using EMRs to capture and store personal information, Infoway believes that clinical analytics will evolve to become a prominent activity. In fact, a standard of practice to inform clinical decisions. Analytics will drive improvements in patient processes and outcomes, improve the health of populations with chronic conditions, and enable a spread of innovation among clinicians and clinician research networks. So what are some of the action items that we believe will set a practice in motion, or if it started already down its analytics path, help it gain momentum? Well, there's three columns here that I'll review with you quickly. The first relates to leadership, the second collaboration, the third execution. From a leadership perspective, we support that each practice really needs to have someone lead and champion the use of analytics. That individual can be charged with providing focus for the group, facilitating the use of analytics, and of course, ensuring that there's some accountability or follow-on action on the basis of the reporting of standardized metrics. We believe that all practices should contribute to governance, particularly if they're involved in shared initiatives or networks. They should be part of it to ensure that shared network's success. Quality planning is an important part of all of this. As I said, it starts with a question, but it's a continuous cycle of that plan, do, check, act that many of us are familiar with as it relates to quality improvement. We encourage the use of a strategy roadmap. We encourage that organizations would review that roadmap from time to time and make changes in relation to a shifting landscape that may move priorities that were formerly thought the correct direction to course correct should that need to be happen. And of course, we believe that leadership is one of not just providing direction, but recognizing success and communicating that success. From a collaboration perspective, there are, as I've noted to you already, many communities of interest right across this country, some national in scope, some regional and provincial. Many initiatives are happening within the community through quality councils. There is several, and I'm sure you're all well aware of what they may be. We just really feel that practices should engage, even if it's through sharing of data in a passive way and starting to take advantage of those reports that might come back to them. But the thing that we drive at here, there needs to be economy of scale. We don't need to all reinvent. We don't need to all start from a whiteboard. There is many artifacts and success stories that should be leveraged to fast-track our startup. We think that there is opportunity to use power of numbers, that where user groups exist for your EMR's vendor solution, that you should work with those user groups to lobby for functional enhancements to your EMR. From an execution point of view, we've mentioned some of this already, but of course there's going to need to be an investment in staff training to develop skills and capacity. We've mentioned the importance of the standardization of data and the use of reminders and alerts, and the standardization of related processes to capture data. We believe that results will be we believe success builds on success, and so we would encourage early adopters and people starting out is to focus on simple, basic descriptive analytics, achieve early success, and replicate and scale that success as you move forward. And of course, particularly for those who may be a little bit further out the gate, we think you should work with others to initiate planning around the advanced use of analytics to include predictive analytics and the use of tools such as natural language processing tools to help you analyze your unstructured data. So I'm going to bring us to a close here, Dennis, with just maybe some takeaway messages. We've experienced, obviously, a dramatic increase in the use of EMRs. It represents a new source of data that's available for analysis. It offers great potential to learn much more than was previously understood about the primary care setting. So it's our opinion that clinical analytics should be regarded as a core functionality, that success will require business transformation to reduce variation within those practices. Many folks who started down this path were obviously in large physician group practices, and they can tell you stories about each physician having a different way of coding the same term, and those kinds of things need to be standardized as we move forward. Good user experience requires access to content with minimal disruption, and this is really about the concept of trying to move analytics from that quarterly report or monthly report or weekly report to be within context of the patient visit so that actions can be taken at the right time. We really expect more functionality, as you likely do, from vendors, and we hope to see continual enhancements of analytical capacity going forward. And last but not least, remember your enablers, including data, algorithm, and visualization, really the three stools, or rather three legs of the stool that will help optimize value for providers and patients. So we encourage you to visit the Canada Health Infoway website. There is a resource center section. You can see there's a screen scrape here. Our full paper, as well as the executive summary of this paper, is available for download. We've also touched on many other subjects and produced white papers that can be found under this tab, Resource Center. So in closing, and before we turn over the call to the questions, our closing comment would be that we hope that the white paper and this webinar has provided enough context and meaningful information to contribute to the strategic discussions and the approaches to the adoption of clinical analytics in the primary healthcare sector in Canada. So now we've arrived at time for some questions, and I think, Dennis, you've been collecting some of them?
Yes, thank you.
Dennis may join me in responding to some of these questions.
Thank you very much, Mark, and hopefully you found this very informative. I think one of the key takeaways for me around this, other than our passion, is there's a lot of opportunity to broaden our use of health analytics in the Canadian healthcare sector. We believe it generates a lot of value, but we have a lot to do to take action to move this agenda forward, and hopefully this will help you move it forward within your organization or within your practice if you're a clinician. So yeah, we have about 10 minutes, so we'll take questions until the top of the hour. We did get a couple, Mark, and a couple of them are somewhat related, so I'm going to ask kind of both halves of this at the same time, and maybe we can address them together. One is related to kind of the skills function you highlighted earlier as a potential barrier. The question is really around, are the professional schools teaching their graduates about analytics? And that kind of gets to the second part of the question as well. Maybe if I'm in a family health team, I've got the strength in numbers to apply this in my practice, but if I'm a solo doc, with very limited resources and knowledge and skills in this area, how do I get on this path to employ health analytics? And more specifically, this person asked about getting on this path towards better data quality so the data could be used for informed decision making.
So those are great questions. I'll start with the first one. We as an organization have been encouraging the change in curriculum not only from a few years ago as it related to teaching new students and graduates about the use of electronic medical records and electronic health record in their practices, but also the power of data. We do know that there has been changes in curriculum, and for many who are interested in specializing in this area, we've seen graduate degrees be developed by universities across Canada for health analytics and the use of health information. So I believe that academia is responding to it. There's probably a lot more room to grow in that particular area. There are a number, for practicing clinicians now, there are a number of peer leadership groups. And in fact, in the paper, we recognize some of the initiatives that have been in place for a while. Some are sponsored by Canada Health Infoway, others by other national organizations, that these peers help those who are asking for help, who need help, to move their practice from its current state to the future state. In the paper, with respect to data quality, we make several references to organizations and some of these initiatives that I've spoken to already today who have developed tools to help primary care clinicians become more standardized in their coding of their patient assessments and the records that they use. So there are many resources available to you, and we encourage you to go to the paper to find reference for some of those.
Another question here around dashboarding and reporting. It's great, especially when you look at it on a population level, but there's often a need to tie it back to the individual patient so the clinician can take some action. How should that be done? What are your thoughts on that?
So I think that's why I included the Emerald Sapphire 2 slides there. You saw a great example of, I guess, at an aggregate level, how a physician's practice was performing. There's some descriptive analytics about the number of diabetics and then how that physician's management of that patient cohort compared to the broader database. That's fine. You can understand that you're trailing those with the gold stars beside their names, but how do you actually improve your performance? And I think what they've done a good job of, and others have as well, is being able to drill down to the patient level where you can see specifically that it's, these 17 of my 45 patients that have been included in this analysis are missing some standards of care for diabetics. I now have an opportunity to make direct contact with those patients to bring them into the office and ensure that those, let's call them gaps, to ensure that they receive the care that they should be receiving. So a lot of it is about internal reflection, and I would agree, without patient-level information, taking the action is less informed.
I think maybe the other lesson here is embed that capability right in the EMR, so you're dealing with the most current data and taking action perhaps right during the patient encounter, or it may require a follow-up encounter and invite the patient back in for a follow-up visit where appropriate action could then be taken. So, the currency of the data is critically important. The currency of the action by the clinician and by the patient in managing their own health care are also very, very important.
Now, the other thing that we've mentioned in the paper and the presentation here today was the use of reminders and alerts and notification. That can happen in the context of a patient visit, but some of the things we hear, and I'm sure many people on today's call can appreciate, is that you can get a fatigue from that. There's sometimes those are false notifications, and hence my comments earlier around the quality of data to ensure that people pay attention to alerts.
You mentioned earlier as well about up to 80% of the data in a clinical record is text. You also mentioned natural language processing. What are your thoughts and recommendations on applying natural language processing to health analytics using primary care data?
Well, we think, let me tell you, I spoke to a number of physicians, and many of them think it's utopia. They think there's no point in changing physician behavior as it relates to coding, because natural language processing can solve for that problem. So you have a group practice of 20 or 40 or 60 or 100 physicians. They have 40, 50, 60, 100 different ways of describing the same term. that's okay. Don't change them. Provide a solution that can map all of those different variations to a standard term. Yeah, I think that's possible. But that's also probably reaching well into the future, and so I think it's a little of both ends, that we do need to try to introduce standardization in our coding at the point of capturing that information. There are available, we make reference to the paper, standard common coding infrastructure that is available. CIHI, together with us and other stakeholders in the country, have developed such a solution. So encourage you to look at the paper to find out more about that. There are other folks who have used natural language processing that I've mentioned here today that have demonstrated that they can take free text data and to link it, map it to SNOMED CT terms. So that work has been done in Canada, and I suspect we'll see more of it going forward.
You also mentioned the use of third parties for some of the more advanced capabilities. Do you know of any successful examples where healthcare providers are using these third parties for primary care data analytics?
Well, I think we've mentioned a lot of them. You know, all of the examples that we spoke to were groups of either clinician researchers conducting research on behalf of the members of their initiative, but also providing quality reporting back to them so they can alter their performance on a set of metrics. A lot of descriptive analytics going on there. Simpson, of course, is an example of an initiative that has gone beyond basic descriptive. They have used natural language processing and have expressed interest and done some predictive analytics. In fact, we think that they are able to step up their level of activity with the right support and funding.
Well, I want to thank you, Mark, for this very informative presentation, and thank to all the participants for joining us today. Just as a reminder, the recording and a version of the presentation will be posted on our website in the next few days. We welcome you to download that information and view the recording, and please do share that information with your colleagues. Certainly share the links to the papers with your colleagues as well. So once again, thank you very, very much for joining us.
And thank you again for joining us today. This concludes today's web conference. You may now disconnect. Have a wonderful day.